Right, so try to understand the basis of the different anatomical and functional techniques in the investigation of both stable as well as acute chest pain, the relative merits and limitations of the techniques, and how can we best combine the different techniques for best possible diagnosis and patient management. So the two anatomical techniques that we have so far covered are the conventional invasive coronary angiography, and second is the CT cardiac angiography, including calcium scoring as well as a contrast coronary angiography. And the second group of techniques we can say are these functional imaging techniques or the stress imaging techniques, which we can perform with either echo, with MRI, or with nuclear techniques, either of them. And there are also ways by which the two techniques, anatomical and function, can be combined as hybrid imaging. So just recap the different causes of chest pain. If we classify the chest pain broadly into stable chest pain and acute or unstable chest pain, so what are the causes of stable chest pain? So angina is not a cause, it's a manifestation, it's a symptom. So coronary artery disease, okay, that's the commonest cause. What else would you say? What else can cause symptoms of stable chest pain or angina? Okay. Sorry? Embolism, coronary embolism, but there will be acute chest pain, wouldn't it? Yeah. So stable chest pain, so you have aortic valve stenosis. Yeah. Anything else? What else can cause stable chest pain? Hypertrophic cardiomyopathy. Anyone think of that as causing chest pain? Pericarditis. So there are lots of conditions, and so those four conditions which I've just said, plus there can be non-cardiac causes of stable chest pain like pleuritis, pneumonia, pulmonary embolism, and there can be GI causes as well, and also musculoskeletal causes. Costochondritis can cause chest pain. Okay, so those are the stable chest pain. Then what are the causes of acute chest pain? Again, the commonest is blockage, acute thrombotic occlusion of the coronary arteries from atheromatous disease. That's the commonest. What else can cause acute chest pain?
Dissection.
Sorry?
Aortic dissection.
Aortic dissection. Pulmonary embolism. Pneumothorax, yeah, okay. So the commonest cause by far is the acute occlusion of the coronary artery, then coronary embolism, spasm or dissection of the coronary artery, that can also cause acute chest pain. Then you have the non-coronary cardiac causes, which are myocarditis and pericarditis. They can present acutely. What Dr. Keegan in his MRI talk showed some examples of myocarditis. Then hypertrophic cardiomyopathy can present acutely with chest pain. Then aortic valve stenosis also we see as incidental or perhaps the cause for patients presenting with acute chest pain. And then type A aortic dissection and pulmonary embolism. So there are several causes that from imaging point of view we have to be aware of. So a cardiologist wants to know first and foremost from imaging what is the diagnosis, what's the cause of the chest pain. And secondly, cardiologist needs to know what is the risk of future events, what's the prognosis from that particular diagnosis. So if you look at stable chest pain, the commonest cause is formation of atheroma, which subsequently causes narrowing of the coronary lumen or stenosis. The history is the most important thing, aspect in evaluating any stable chest pain patient. And that you can classify angina into three stages or three types. Non-anginal chest pain could have atypical angina or typical angina. So I'm sure cardiologists among you would know what the three different terms mean. We're going to say what is non-anginal chest pain, or let us say what is angina. how do we define angina?
Chest pain insertion.
So chest pain, first of all, it's occurring in the chest, retrosternally constricting, could be radiating to the left arm or the jaw. Second point, it happens on exertion. And the third feature is that it's relieved by rest, or GTN. So if you have all the three features, then the chest pain is angina, typical angina. If you have two of the three features, it's atypical angina, and if you have one feature alone, that's just chest pain, with no exertional relationship, then it's non-anginal chest pain. So that is very important. And on the basis of the type of angina, on the basis of person's age, sex, and risk factors, you determine the pre-test likelihood of someone having atherosclerotic disease. Then there is physical examination, resting ECG, and chest X-ray. These all things that Dr. Fox has spoken about early in the morning. So this curve is called Gould's curve. It's a very famous, well-known physiological experiment which shows on the x-axis the degree of stenosis in the coronary artery, on the y-axis the amount of blood flow in the coronary artery in liters per minute. So what this is showing us, that the flow in the coronary arteries at rest remain fairly normal till you get beyond 80% diameter stenosis in the artery. Only after that it starts to reduce. But if you exercise or stress a patient with any means, then the flow reduces at about 50% or more diameter stenosis. Obviously, more the diameter reduction is, the more reduction in the flow happens. So this curve, to my understanding, is the basis of both anatomical definition of more than 50% stenosis as being like the cutoff point, perhaps 70% being more specific, and this is also the basis of physiological stress imaging that we use in daily practice. Okay, so this is very important physiological information. So let's come to the anatomical imaging. So conventional catheter angiography is the gold standard, as you know. So what we're looking for is the degree of luminal stenosis on the angiogram. So it's an example here of a stenosis in the proximal LED. And the stenosis is roughly graded as being mild if it is less than 50%, moderate between 50 to 70%, and severe if it is more than 70% diameter stenosis. And the word diameter is important because on angiography we can only look at diameters. We cannot calculate areas on conventional angiograms. And if you can do quantitative analysis of the diameter stenosis on the software, but this is not done in daily practice, but only for specific research purposes. Through the conventional angiography, you can introduce intravascular ultrasound probe and assess the degree of the plaque in the wall of the coronary artery and look at the luminal stenosis as well. It's an example whereby this patient has a lot of atheroma in the coronary wall, but the coronary artery on the angiogram appears to be unremarkable. So just showing that the catheter angiogram is simply a luminogram. It does not show or demonstrate the plaque in the wall. So it underestimates the degree of coronary artery disease. And this we see every day in our practice when we do CT angiograms, because that shows us the plaque in the wall. So then, starting with a non-invasive technique for coronary artery imaging, you have the crude basic coronary calcium scoring. So calcification in the coronary arteries on these uncontrasted scans means that these are calcified plaques in the coronary arteries. The more the plaque you have, the more chances of there being obstructive disease. Higher the number, higher the amount of plaque. We can quantify these plaques on the software, which we'll practice on the workstation here, and it gives us a score. And we can also relate it to the patient's age and sex percentile as well. Absence of plaque is also quite useful to have, because that means the chances of someone having significant disease is very low. So what does it mean? So there were studies performed in early last decade in which patients were undergoing invasive angiogram and patients had CT calcium scoring. So there are 18 such studies totaling around 10,000 patients, and they showed that if you have a calcium score of 0, then chances of having more than 50% stenosis in the coronary arteries is around 2% or less. Okay? And these were patients with typical angina who were undergoing invasive angiogram. Then we started to have CT angiography coming up in last few years, and there was one study that showed that the incidence of significant CAD in those with calcium score of 0 is around 2%, so same as the catheter studies. But then there were other studies showing that the incidence of significant stenosis could be as much as 19%. So very high. So they started to say that you cannot rely on absent calcification in coronary arteries. You have to do some angiographic study. But if you look at the patient profile that they had included in their studies, so in the first study, which had 2% significant stenosis, most of the patients had low to intermediate pretest likelihood, while the other two studies had significant proportion of patients with acute coronary syndromes. So the important message from this is to understand that calcium score of 0 works well if someone has stable chest pain, but not in patients with acute chest pain, where you can have young people who smoke, who have suddenly disrupted their endothelium and developed acute thrombus in their coronary artery. So similarly, there was a large multi-center observational study in more than 10,000 symptomatic people where both calcium scoring and CT angiogram was done. And they also showed that the prevalence of significant stenosis in those with absent calcium is around 3 to 4% only. So we have plenty of evidence to suggest that absent calcium is a reasonably good marker of significant stenosis. But we also, if we did do a stress imaging in those with calcium score of 0, then the prevalence of true flow limiting stenosis will be even lower. I think it will be even less than 1% or so. So hence it is a very good test. And also studies looking at the prognosis, the outcome in those with calcium score of 0 compared to those with calcium score of more than 0 have shown that the rate of cardiovascular events is very low if you have a score of 0. So this is less than 1.8% over 4 years. So it will be 0.5% or less each year compared to if you have any degree of calcification. Okay? So the role of CT angiogram, which is now becoming a rapidly expanding technique in investigation of patients with chest pain, stable chest pain, is that it shows the luminal narrowing because of contrast, but also shows us the plaque in the wall of the coronary artery. And you can see here there is a plaque which has got calcium, but also has a soft component to it, and that's the lumen here, it's the luminal stenosis. So look at the plaque morphology as well as the luminal stenosis can be done. And one can look at the stenosis by comparing diameter of the lesion with the reference diameter of the vessel, or you can calculate and outline the area of the stenosis and reference it to the area at the reference point. Okay, so in terms of accuracy, this is an old meta-analysis now on 64-slice cardiac CT angiography. It shows a very high sensitivity of almost 99%, specificity of 89%, a positive predictive value of 93%. I think this was in research studies, but in practice, the positive predictive value is around 65 to 70%, which is still a slight limitation. But the negative predictive value is very high. It's more than 95%, which is the strength of cardiac CT angiogram. So a normal cardiac CT angiogram literally means there is absent of significant obstructive disease. That's the strength of CT. Okay? Another strength is that CT shows plaque. because it's the most sensitive technique to show calcium at least. And you cannot miss patients with left brainstem disease or three-vessel disease. Okay? So these patients could have, if you do a stress imaging test, they could have relatively normal perfusion throughout their myocardium, because stress perfusion techniques are relative techniques. So you could miss perfusion defects because of that, because of balanced ischemia from three-vessel disease. But something like CT would not miss plaques. It will just show you that they are there. And again, the more severe plaques you have on CT angiography, the worse your outcome is. Okay, so these are studies like this showing the prognostic value of CT angiography. So let's look at functional imaging. So again, as I said, this curve is very important. So increase in blood flow from rest to exercise state is called our coronary flow reserve. So normal flow reserve is around 3 to 4 times. Yeah. So reduction in flow reserve means that there is ischemia, and this is the basis of any of the stress imaging tests. So if you have, so that's the normal artery with normal increase in blood flow. If you have, on the other hand, if you have severe stenosis, then you may have reduced blood flow or absent blood flow on rest, and also absent on stress. If you have moderate stenosis, then you have more normal blood flow at rest, but reduced blood flow at stress. Okay? And that's what we're looking for, this particular situation on stress imaging. So this is a summary slide of different stress imaging techniques and the stress imaging agents we use. So commonest stressing agent, and some people strongly believe exercise is the best stressing technique. Then you have inotropic agents like dobutamine, which we use with echo particularly. And then we have vasodilators like adenosine, which we used again with SPECT, MRI, or now beginning to use with CT angiography as well. So the response that we see with any of the techniques depend upon the type of stress we have used and what that modality can show us. So exercise test we can use just by its own, which has been a traditional way to assess patients with stable chest pain, and look at symptoms or ECG changes during stress. We can use exercise with echo to look for regional wall motion abnormality. We can look exercise with SPECT or PET imaging and look at the reduction in tracer uptake. Okay. We can use dobutamine with echo and MRI because dobutamine is a chronotropic agent, so it's increasing the contractility of the myocardium. So any technique that shows that, like echo or MRI, you can use to see the response, what happens. Adenosine is increasing the blood flow through coronary arteries. So any technique that shows perfusion of the myocardium, we can look at, assess the ischemia with that. So SPECT, MRI, and CT are the 3 techniques we can use. Is that clear? This is a summary slide. So more or less, they're showing same thing, similar thing. The mechanism and the imaging technique used may be different, but the purpose and application is similar. So this example of a nuclear stress study. So here you can see a rest perfusion being completely normal, and on stress this patient has, this is a normal studies, and rest also there's perfectly normal uptake similar to the rest imaging. This patient has reduced uptake of the tracer in the inferior wall and becomes normal on the rest images. So that means this patient has ischemia in the inferior wall. Then in terms of prognosis with functional studies, this is data from nuclear imaging, show that if you have a normal nuclear stress test, your chances of having MI is very low, less than 0.4%. But now new literature suggests that it is not as low as we thought it would be. It is dependent upon a number of factors like pre-test probability and coexisting comorbidities patient may have, and also presence of non-obstructive atheroma. So there was a study performed with PET perfusion and calcium scoring, and that they showed that in about 600 patients, that in patients in whom there was no ischemia on stress, on PET stress test, if you had a high calcium score, your prognosis was worse compared to if you have a lower calcium score. Okay, so that indicates that presence of atheroma by itself, even though it may not produce obstruction, has an important bearing on our prognosis. Okay, does it make sense? Because stress imaging will be positive only when you have obstructive disease. So when the atheroma becomes so much that it's reducing the blood flow on stress, only then stress will be positive. But that doesn't mean a negative stress imaging does not mean there is no atheroma. So that's a very important basic fact that we have to be very clear about it. So while the stress imaging techniques all are relative perfusion techniques, so in patients with 3-vessel disease, you can have an absolutely normal looking myocardium if there is equal reduction in the blood flow in all the 3 coronary arteries. Okay? So then what do you do in those cases? So the best way to do is to quantify the actual blood flow in the myocardium on rest and stress. If you see absolute reduction in blood flow, then you can say there is reduction in the, there's reduced ischemia in the myocardium. And we can do that. The PET-CT is a gold standard for doing that, for quantifying, but we're also be able to, in theory, do it with cardiac MR and also with cardiac CT. Okay. That's important. In the cath labs, now we are using what is called fractional flow reserve. And that's become a very important tool to assess the functional significance of stenosis, particularly a moderate stenosis. Okay? So patient has an angiogram, and cardiologist sees there's a moderate stenosis in the coronary artery. So what does it mean? Is it causing functional reduction in blood supply or not? Does not. So to identify that, one can do what the fractional flow reserve. So you pass a wire with a transducer at its end distal to the stenosis, and you induce maximal hyperemia by giving intracoronary or intravenous adenosine, and you measure the pressure distally and proximal to the stenosis, and the ratio of that is called fractional flow reserve. So if the stenosis is functionally significant, then the ratio will be less than 0.8. Okay, various cutoff has been described, but 0.8 is probably what people are taking as standard. It makes sense? So this has become a very important tool for cardiologists to assess and treat coronary artery disease. And this is an example of normal pressure distally and pressure proximally, and the ratio of that. So they should be, the two curves should be equal in a patient with no significant ischemia. And there were a number of trials published on using the FFR in the labs in different categories of patients, particularly those with intermediate stenosis. And patient outcome is better if you treat the patient based on the FFR results. Okay, so now comparing the CT anatomical technique with the stress imaging techniques, you can see that CT, by virtue of its picking up plaque in the wall, it has got higher sensitivity, which is what it should do, you would expect. Specificity, I think, is probably similar. Positive predictive value, like as I said, is in the region of 65 to 70%. I do not know what the positive predictive value of stress imaging is. And negative predictive value is the strength of CT, which again, I would think a normal stress echo will miss out easily 10 to 15% of disease there. Now, the other important thing to understand is the relationship between the severity of stenosis on anatomical imaging when you compare with the functional imaging is not very good. And various studies have shown that there would be patients where you have less severe stenosis on anatomical imaging, but you may have severe functional reduction in blood flow, and similarly vice versa. But it is true that more severe anatomical stenosis you have, the more likelihood you will have functional ischemia as well. So this summarizes what each of the techniques is good for. So cath we know is the gold standard for anatomical stenosis, although CT angiography is reaching that point with its not higher, but increasingly higher spatial resolution. Calcium scoring shows us the plaque itself, but not the degree of luminal obstruction. And obviously stress imaging does not show us anatomical stenosis. For ischemia, you can do invasive FFR, or you can do any of the stress imaging techniques. To assess plaque burden, I think CT angiography is the best technique for this, followed by calcium score. Or if you do IVUS with invasive angiography. To assess non-coronary cardiac abnormalities, you can use CTA for that. You can use echo or CMR. For non-cardiac abnormalities, CT techniques obviously are the best. CT or MR technique is good for that. In terms of radiation burden, this has got moderate radiation burden. CT depends upon the scanner you're using, the technique you're using. You can have very low dose CT angiogram to a high dose CT angiogram. And we know with nuclear techniques there is moderate radiation dose involved. Now, prognosis with any of these techniques is an important concept. And to me, prognosis means freedom from future cardiovascular event. That's prognosis. So if you take a stress imaging technique, if that is normal, that gives you a good outcome for, say, next 3 to 4 years, because it is showing that there is no obstructive disease, but there could still be plaque in the coronary arteries. If you take something like calcium scoring, that is showing you a negative absent calcium score means there is no calcified plaque. But it doesn't mean there are no soft plaques. There may still be soft plaques. Okay. So it is better than stress imaging techniques, but less better than something like CT angiogram, which shows us not only the lumen, but also the plaque in the wall of the coronary arteries. So to me, that's increasing benefit, you can say, or increasing warranty you get from techniques as you go further from stress to anatomical imaging. Does it make sense, this slide? Okay. So there are two different pathways one can use in clinical practice in terms of combining anatomy versus functional imaging. So one pathway could be, you can start with calcium scoring scan. If calcium score is 0, you can label the patient as having non-cardiac chest pain. If the calcium score is more than 1, you do a CT angiogram. If it is less than 50% stenosis, then you simply treat patient with prevention, secondary or primary prevention. If you have moderate stenosis, then here you can do stress imaging to define whether it is functionally significant or not. If you have severe stenosis, you do a cath. Okay? Or you can start with functional pathway, whereby you do stress imaging. If the ischemia is absent, then you don't need further investigation treatment. If it is there, then you further image that with cath. So there are pros and cons of both pathways, but to me, this pathway is somewhat better because it shows us the plaque burden in the coronary arteries, which we miss out on this. So unless we combine a plaque imaging of some sort, we are not assessing the coronary artery atheroma burden in patients' coronary arteries. And this you have seen in the initial Dr. Fox's presentation. This is the chart that the NICE guidance gave us to calculate a patient's pre-test likelihood of having significant coronary disease. And this is based on the age of the patient, the sex, and the kind of chest pain, non-anginal, atypical, or typical, and the presence or absence of risk factors. And these numbers represent the likelihood in numbers of having significant coronary disease. Okay. Okay. And this suggests this guideline suggests that if you have pre-test likelihood of less than 10%, then you don't need to do anything. You consider the chest pain as non-cardiac. If the pre-test likelihood is between 10 to 29%, then you start with calcium scoring. If it is between 30 to 60%, you do a stress imaging test of whatever is available in your institution. And if you have between 61 to 99% pretest likelihood, then you do invasive angiography, if appropriate, meaning if patient symptoms also relate to typical angina. So that's about the stable chest pain. Now, acute chest pain is a totally different ballgame. Okay? And the word acute chest pain or acute coronary syndrome is a very broad term. And it's obviously sudden constricting chest pain that one may have. The first thing that these patients need is a 12-lead ECG. So a patient calls the ambulance services having a constricting heavy chest pain in the chest. The paramedics come to patient's house, they do a 12-lead ECG. So the first differentiation has to be between is the chest pain because of ST elevation MI or is it non-ST elevation MI? Okay. So this is the first important classification. So you have to exclude STEMI, and these patients have to be triaged very quickly, rapidly to a hospital with facility to do invasive angiography, ASAP, and subsequent PCI if there is obstruction. If the ST is not elevated but is, shows non-specific changes or is normal, then patient could be taken to an A&E, have troponins measured over several hours. If troponin is high, that chest pain is labeled as non-STEMI, and if there is no troponin, then that ACS is called unstable angina. So this is the current definition of acute coronary syndromes, chest pains for last few years now. And the management is very different in all the three conditions. So that's why this is very important to understand. So this is an example of a patient presenting with STEMI. So it has occlusion of the right coronary artery. You can see it there. And this is probably another, because this is a stent with a balloon in the LAD. So this is what's done in patients who present with STEMI, acute coronary syndrome. Now, so there is no role of non-invasive imaging in patients presenting with STEMI before they've had their cath. Okay, so no wasting time. They have to go straight to a hospital, and they have to straight go to the cath lab. If there is no hospital with primary PCI facility, then they have to be taken to a hospital with thrombolysis. Okay. Sometimes they go to a thrombolysis hospital and they then refer to a primary PCI center also. But after they've had their PCI, their cath, they then can undergo non-invasive investigation depending upon what exactly is happening to them. So some of these patients would have developed acute heart failure because there has been large infarction involving one of the coronary artery territories, particularly the LAD territory. It's a large area of myocardium that can be infarcted, and these patients can have acute heart failure. So a chest X-ray could be very useful to exclude pulmonary edema. Then echo and MRI again to assess ventricular function, to look for any regional wall motion abnormalities, etc., etc. Then sometimes they would have complications like rupture of the papillary muscle, VSD, and they need to be evaluated as soon as possible for this, as soon as these complications are manifested with echo MR. Then you would have one main coronary artery which was the cause of the infarction, but you may have disease in the other coronary arteries also, and that disease is called bystander disease. Okay? Sometimes the disease is minor, nothing needs to be done, but it can be moderate in degree, in which case we have to do stress imaging tests to assess the functional significance of that stenosis. We also sometimes, it's not become a clinical area application yet, but to look at how much myocardium has infarcted, how much is alive. So that's assessment of myocardial salvage. How much has the PCI actually saved the myocardium from becoming infarcted? And that we can do with MR or with nuclear techniques. So this is all looking at disease as different aspects of the heart after the thrombolysis or after the primary PCI. Now, patients who do not have STEMI, who have non-STEMI, they are risk assessed in the hospital with different scoring methods, clinical scoring methods. And in those with low likelihood cases, they could be suitable for CT angiography or stress imaging. Those with higher pretest likelihood, higher risk, they would undergo a catheter angiography, followed by PCI if required. They also need assessment of their ventricular function with different techniques. Okay. For unstable angina, generally these patients are observed on the wards with ECG monitoring, with troponins, etc. Now, imaging can play a role in these cases, and patients in general are discharged and they have the imaging as outpatients often. So you could do stress imaging of some sort, you could do CT angiography in these patients, and there are various studies looking at the role of these different imaging techniques in this group of patients. Okay, so summary. So coronary disease is the most frequent cause, but we have to think of other causes also. And tomorrow morning we will look at the other causes of chest pain that these patients can have. History and risk factors and calculating the pretest likelihood remains important to assess the pretest likelihood. Now, we also looked at that Gould's curve to understand the anatomical and physiological basis of ischemia. The use of anatomical strategy first defines the plaque burden and degree of stenosis leading to stress imaging and cath if required. If you use stress imaging first, then you do evaluate ischemia, but you may miss the plaque in the coronary wall. But important thing is use of stress imaging and or FFR is essential to guide any revascularization with PCI or CABG. Okay? And strategy of using imaging in stable chest pain as per NICE guidelines is what maybe some hospitals are following, some are not, some are totally ignoring the NICE guidelines. So in STEMI, catheter angiogram is the primary investigation tool with a view to PCI or bypass surgery. In our hospital, all patients with STEMI also have a chest X-ray and echo once they're stable, before discharge. They can undergo nuclear or any other stress imaging, MRI of the heart or CT depending upon other clinical parameters. And patients with NSTEMI and unstable angina again are assessed according to the risk and investigated further depending upon the pretest likelihood. Okay, thank you.